When a hurricane approaches, emergency crews rush to board up the windows and sandbag the doors. They secure the physical structure. But once they leave to prep the next block, the family is still sitting inside in the dark, listening to the wind howl. Modern end-of-life care operates exactly the same way. Oncologists and ICU nurses perform highly technical, life-saving perimeter work. But for decades, our medical infrastructure has largely neglected the emotional interior of the dying process. In the late 1960s, Dame Cicely Saunders attempted to build that interior support when she founded the modern hospice movement. Her original model provided a deeply compassionate, holistic environment. It was meant to be a true sanctuary for terminal patients when curative treatments failed. Over time, as healthcare grew increasingly complex and tied to insurance billing and Medicare regulations, that vision faded. Hospice nurses carried massive patient loads, and the care shifted toward clinical metrics and task-based checklists. The system built to comfort the dying hyper-medicalized the process. Death became a clinical failure that needed to be managed, rather than a natural human transition requiring support. In 1998, a birth doula philanthropist named Phyllis Farley attended an end-of-life seminar, looked at this highly clinical approach, and asked a simple question: why aren't we doing what we do for birth, for the dying? The birth doula movement had already proven that physiological transitions could be safely supported through non-medical advocacy. Farley realized that this exact blueprint could be applied to the very end of the human life cycle. 5 years later, Henry Fersko-Weiss, a licensed clinical social worker and a Zen Buddhist, built the structural bridge. He adapted the physical presence techniques used in birth support, applying breath awareness and somatic mindfulness directly to anticipatory grief. This chart shows the rapid adoption of that model. In 2019, the National End-of-Life Doula Alliance had roughly 260 members. Today, networks like the International End-of-Life Doula Association have trained over 10,000 practitioners operating across 56 countries. This scale forced traditional academia to adapt. Medical colleges, including the faculty at the University of Vermont, began collaborating to build standardized professional certificate programs. What started as a grassroots observation is now a formalized healthcare sector. A massive, structured workforce is actively claiming a place at the medical bedside. This new workforce operates under a strict boundary. Death doulas never administer medication, they do not perform physical diagnostics, and they offer zero clinical advice. Their scope of practice is entirely non-medical. Instead, they perform what amounts to an institutional audit. They observe the often chaotic medical environment around the patient to identify exactly what is disrupting the human experience of dying. Under Medicare guidelines, certified hospice agencies only need to update a care plan every 15 days. Hospice nurses do incredible work, but their visits are intermittent. Doulas fill these gaps by sitting at the bedside for 8 to 10 straight hours. While nurses manage the physical decline, the doula acts as a sovereign guardian. They manage the tactical perimeter of the room. That means dimming harsh hospital lights, curating familiar music, and physically intercepting well-meaning but overwhelming visitors at the door to prevent sensory overload. A death doula does not fix the physical body. They aggressively protect the patient's agency and psychological safety from institutional interference. To maintain that safety, they rely on highly disciplined somatic skills, like deep, active listening. By consciously regulating their own breathing and nervous system, the doula acts as a physical anchor in the room, ensuring that a family's panic doesn't become contagious. For specialized cases, like severe cognitive decline, dementia doulas use validation communication. This allows them to manage agitation and psychological distress without relying on psychiatric medication. This diagram illustrates their core methodology, the Platinum Rule. By deploying these structured emotional tools, the doula lifts the heavy burden of room logistics. Relatives no longer have to play amateur nurse or host. They get to simply be a family. The clinical value of this preparation becomes most obvious during what practitioners call the 2 a.m. crisis. A terminally ill patient resting at home suddenly develops ragged, highly irregular breathing, a natural process known as Cheyne-Stokes breathing. In a standard scenario, the family has no medical training. They panic, assume their loved one is suffocating, and call 911. Paramedics rush the patient to the hospital, and their life ends in a brightly lit, chaotic emergency room trauma bay surrounded by strangers. The sanctuary outcome looks completely different. Because a doula initiates conversations months early, the family is prepared. When the irregular breathing starts, the doula calmly explains that it is normal. The panic is de-escalated in real time, and the transition remains peaceful and at home. This proactive planning has a direct causal effect on hospital readmission rates. By demystifying the physical signs of active dying, doulas stop panic-driven hospital runs and reduce the financial and operational strain on acute emergency care systems. This empowerment extends past the moment of death. Specialists now guide families through post-death care, teaching them how to safely perform natural body preservation at home and coordinate eco-friendly conservation burials. Upstream doula care provides a highly effective clinical release valve for an overtaxed emergency medical infrastructure. Disrupting a massive established industry inevitably causes friction. State regulatory boards are currently attempting to apply traditional embalming and mortuary licenses to doulas, triggering intense scope of practice lawsuits over who owns the rights to death care. There is also a significant financial barrier. Standard hourly rates for private pay doulas range from $25 to $75. Because Medicare does not cover these services, this level of support risks becoming a luxury reserved strictly for the affluent. To counter this, public health networks have developed the community doula model. These practitioners are embedded directly within historically marginalized neighborhoods to fight systemic healthcare disparities at the street level. This graphic breaks down the staggering hidden workload required in those communities. For every single hour a community doula spends in direct bedside care, they spend an additional 2 hours performing indirect labor, fighting medical bias, navigating federal food assistance, and securing emergency housing. The baby boomer generation, who originally demanded autonomy in birth by inventing the birth doula, is now aging into its end-of-life years. Whether the end-of-life doula remains a private luxury or becomes a foundational part of healthcare now depends on how the medical system resolves these legal and financial tensions. Driven by sheer demographic demand, a generation is again poised to negotiate the terms of a major life transition.